If you're starting to be forgetful, you begin to remember, and there's less disease. But if, and the same thing happens with calorie restriction. Now, if we eat too much and don't exercise and have diabetes and eat a basic American or bad diet, that leads to more oxidative stress. Not a small amount of oxidative stress, a lot of oxidative stress. And that gets in the way and causes degeneration in our neurologic system. So one of the things that we've found within the functional medicine model is that when we see people who have neurologic issues going on, the use of antioxidants can be helpful. But what we also found is the blind use of vitamin A and vitamin C and vitamin E and just throwing synthetic antioxidants at people didn't really have an effect overall. We find that these molecules, these antioxidants, in the right dose can have a great effect, and in a higher dose may actually be poisons. So this is an idea, a new term that's come out that's basically trying to highlight that we can take things that will act in a beneficial way, and if we take too much of them, they will act in a negative way. And that is why we want to look at biomarkers to help us see what's going on inside the system. It comes back to the earlier conversation I had. If I am able to understand what's going on with the amount of reserve of total antioxidant capacity or glutathione, the amount of enzyme activity that's going on, as we talk about here with catalase, glutathione peroxidase, and superoxide dismutase, and I can see if there's any damage that's been done, that will help me to guide what my therapy should be. So when do I think about these things? I think about them if someone has Alzheimer's disease. I read recently in the United States, Alzheimer's has moved to the 4th leading cause of death in the United States. 4th. So my U.S. colleagues are saying, really? And it's like, yes, the 4th leading cause of death in the United States due to Alzheimer's disease that's going on. And we see this with cognitive dysfunction, cognitive impairment. Now, clinically, I want to share something that really kind of caught me off guard. And when I began to understand, I began to be more vigilant about checking people's memories. And there are some great tools that are online that are available for helping people to check their memory and to be able to monitor them over time. And my point is this. Yesterday you heard Dr. Hayes say that that the loss of hair is one of the things that a woman, for example, will find to be very much a motivating factor to change some lifestyle or behavior that's going on. But a much bigger motivator than that is the idea or the awareness that memory function is beginning to decline. It's incredibly useful motivating factor. And I'm not trying to say just do it to get people to do what you want, but when, and I did a study, a case series with a group of women who had menopausal symptoms that were going on. And we measured all different kinds of biomarkers, and we looked at how their hot flashes and things were going. And the thing that motivated them to change their behavior more than anything was the beginning loss of memory function. So I encourage you to use it because it is a signal. It's an early signal of there's something that's going on there before they get all the way on down the line to Alzheimer's disease. Now, as I talk about Alzheimer's for a little bit, want to again go back to Dr. Berry's conversation and Dr. Ho's conversation about functional genomics. There are genetic predispositions towards the risk of developing Alzheimer's disease. And people who have the genetic predisposition of having an ApoE4, this is a particular protein that stabilizes beta amyloid in the brain. And in stabilizing that, this particular protein, people are either ApoE2, E3, or E4. It's an old kind of naming system that was developed in the early 90s before we really understood what this was. But the people who have ApoE2 are much more sensitive to develop diabetes and to high-carb diets. The people who have ApoE4 have more oxidative stress are more susceptible to oxidative stress, and they're more susceptible to high-fat diets. So we see that the E4 has decreased antioxidant function and capacity. So here's an interesting study that was done. It said, let's look at people with and without ApoE4. And we found 9 people, 2% of the population, that had the E4 from their mother and from their father. And 21% of the population had the E4 from either their mother or their father. They had one of their 2 genes had the ApoE4. Now we see in practice is that the people who are in this category will have a 30% lifetime risk of developing Alzheimer's disease. And the people in this category will have an 80% lifetime risk of developing Alzheimer's disease. And what they did was they looked at a simple antioxidant. They used beta-carotene levels, fat-soluble plasma beta-carotene levels, as a way to say, let's follow and see what happens in these people. And what they found was that when the beta-carotene level, the vitamin A level, was high, that those people had almost a 90% decrease in the risk of developing diabetes, of developing Alzheimer's disease. So instead of 30% in the heterozygous group, it was only 3%. That's astonishing. It tells us that there's a relationship that's going on between these things. And so we see studies that then look further at going upstream before you develop Alzheimer's disease. What are the studies that show early in the development of Alzheimer's disease, before you have it, just when you start to have cognitive impairment, are there damages? And the studies show that the things I talked about, lipid peroxides, damage to fats, 8-hydroxydeoxyguanosine, damage to DNA, 2-hydroxy, I'm forgetting there's an RNA measure that I'm forgetting the name of at this point in time. I guess I maybe need to check my memory. And then also protein damage, 3-hydroxy or 3-nitrotyrosine. What they found was that the more oxidative stress these people had, the more likely they were to go on and develop Alzheimer's disease. And the opposite is that the better the antioxidant capacity that they had, the less damage they had going on, the less likely they were to develop Alzheimer's disease. Here's another study, just looking at lipid peroxides. I think your slide says T-bars on it. T-bars is just another name for lipid peroxide going on. And we see that the lipid, rancid fat, when someone has rancid fat in their body, their likelihood of developing Alzheimer's disease, the measurement of the rancid fat in people with Alzheimer's disease is 4 times higher than it is in people who don't have Alzheimer's disease. When we look at fat-soluble antioxidants, in this case looking at vitamin C, vitamin E, vitamin A, we find that in the Alzheimer's groups they had lower amounts of these plasma measured antioxidants. What about in the group of people who use both vitamin C and vitamin E on a regular basis? Almost an 80% decrease in the risk of Alzheimer's disease. So now we're seeing, wow, antioxidants actually make a difference in the development of Alzheimer's disease. Who would have known? Now let's go from Alzheimer's disease to talk about Parkinson's disease for a moment. Recall that I said in the electron transport chain, we go from cytochrome 1 to cytochrome 2 in handing off an electron. In that process, the way in which that moves is with CoQ10. CoQ10 is necessary for energy production that's going on. So in people with Parkinson's disease, where they have oxidative stress that's happening in the part of their brain that controls movement, when we give them CoQ10, look what we find. We find that when we give them placebo, they don't do very well in terms of their overall Parkinson's rating that's going on. But when we give people 1,200 milligrams of CoQ10 to help energy production in their mitochondria, wow, look, they bounce back. And then when we step back and we look at why would people have problems with CoQ10? And we look at this list of medicines that are there that are commonly used in Western medicine. All of these drugs, here are the most common ones: beta blockers, antidepressants, diuretics, antidepressants, as well as the statin drugs. The statin drugs, some of the most prescribed drugs in the whole world, will deplete CoQ10, will deplete your energy supply. Now you can, if you're giving these drugs, give CoQ10 with it. I'm not saying don't give the drugs, but just recognize that all of these drugs, the ones in yellow, which are more commonly used, will all cause CoQ10 to be depleted. Are your patients depleted in CoQ10? And did you know that you can measure CoQ10 directly in the blood to see how your levels are doing? So we're talking about Parkinson's disease. So not only is there this issue related to CoQ10, but we also find that there's a relationship with exposure to toxins. What's causing some of the oxidative stress that's leading to increased damage and the need for higher amounts of antioxidants in patients with Parkinson's disease? And one of the things that we're finding is that the exposure to various kinds of pesticides. Dr. Roundtree talked about this yesterday a little bit. Here's an example of 700 residents in the Central Valley in California, where massive amounts of food that feed the people of the United States are grown. And what they did is they compared the risk of Parkinson's disease to who was actually applying the pesticides. And what they found is that in the group of people who were applying pesticides, these two different pesticides, diazinon as well as propagite, that the people who were applying the pesticides had, what we found is a 60 to 100% increase in the rates of developing Parkinson's disease. And when you have Parkinson's disease, you have very, very low levels of glutathione. Our friend and colleague, Dr. David Perlmutter, a well-known neurologist in the United States who's done a lot of work with nutrition as well, helped with this study where they actually gave glutathione to Parkinson's patients. I was trying to see if I had the video on my computer, but I didn't. It's amazing to watch where you can see in a group of people, and he shows a specific example where they took the Parkinson's disease. This is a universal rating scale for Parkinson's disease, and they showed that after 4 weeks of giving them glutathione, they had a statistically significant improvement. And as soon as they took them off of the glutathione, they got worse again in the Parkinson's patients. So we see in this area of biotransformation and elimination that there are important stressors that we need to consider in the development of oxidative stress, and they have an impact on the brain. They have an impact on the brain because they create not only the reactive oxygen species, but an inflammatory process that goes on. And so the microglia, which are in the brain involved in the immune activation, these microglia in this Alzheimer's patients, we see that it's lit up, completely lit up, where the microglia are activated. We can see various kinds of toxicity that will cause the microglia to increase. Here's the normal microglia, and when it becomes activated, it starts releasing. It releases glutamate. It creates reactive oxygen species. It breaks down ATP and releases all of these kinds of inflammatory cytokines that go on. Releases glutamate. Glutamate as an excitatory neurotransmitter actually causes energy loss within the mitochondria. The mitochondria becomes less efficient, and we see neuronal death happening as a direct consequence of the inflammation from activated microglia. So as we go through looking at the brain, what we end up seeing is that there's an inflammation that's going on. So Alzheimer's disease has a relationship to what's happening not only with oxidative stress, but also, as we'll see, with the development of inflammation. And so in Alzheimer's disease, we see a stimulation of inflammatory cytokines that are going on. So we say, well, we can use antioxidants. We also may want to help to decrease the production of these amyloid plaques that are just the consequence of the body's trying to deal with the inflammatory reaction. And we can start to look at using anti-inflammatories. So in fact, there are studies that have been done now using curcumin and curries to be able to treat Alzheimer's disease. Now, the doses of curcumin in this study ranged from 2 to 8 grams per day. That's a large dose of curcumin. But we found that when we gave curcumin, we were able to reduce the oxidative stress, and we were able to decrease the amount of plaque that was present. So there's decreased oxidative stress, decreased inflammation, decreased plaque from the use of curcumin. Here's some studies that just illustrate that point. So we find we see the use of things like curcumin, we see anti-inflammatories, we see antioxidants that are present, all of which will have an effect, as curcumin does here. Oops. Curcumin, green tea extract, sulforaphanes, garlic, and DHA, these omega-3 fats, all of them will work through the body to create this anti-inflammatory molecule called NRF2. In your notes, there's a lot more information about NRF2. Activating the DNA to produce the signal that is the anti-inflammatory NRF2 is an important cascade. It's an important treatment approach that we will be developing over time. There are more and more agents that we find, including, as I said, garlic, DNA, the sulforaphanes, green tea extract, curcumin, that stimulate NRF2 production. Whoops. And when we stimulate NRF2 production, it actually helps to decrease inflammation and decrease oxidative stress. So all these are like the chemicals that help the brain to grow, that help new brain, neurogenesis, brain regeneration to happen. So in the last part of this talk, I'm going to highlight some of those factors that can make a difference. And one of the factors that we see is in relationship to what things are going to help this brain-derived neurotrophic factor, this regeneration process of the brain to occur. Brain regeneration can occur, and the things that make the difference, I've mentioned before, are going to be calorie restriction, physical exercise, the omega-3 fat called DHA, and mental exercise. All of these lead to increases in brain-derived neurotrophic factor, BDNF. So let's look at the data just very quickly. We can see a number of papers here, first showing that when we have a restricted diet, a diet that's restricted, we have higher amounts of BDNF that are formed. So when we begin to restrict the calories, usually by 20 to 25%. So for a male, taking a diet of 2,400 calories, reducing that by 480 calories to 1,900 calories. For a woman, on average, taking an 1,800 calorie diet, decreasing that by 360 calories to 1,440 calories per day. This is what we see in the data. So papers looking at restricting calories, we can actually improve neurologic function that's going on. Here's a study where they looked at BDNF levels in these individuals. And what they found, they put them on a diet 55% carbs, 25% fat. So in this case, this was not a ketogenic diet, it was just a restriction in the overall amount of calories, 25% reduction at 3 months period of time. And what this showed is that the serum BDNF levels went up by almost 80%. More BDNF, more improvement. Now these are in humans, these aren't animal studies of any kind. Another study looking at 50 people with a 30% restriction, and what we see is that overall at 3 months period of time, their memory scores, look at this here, the memory scores went from 94 to 127. We saw an almost 50% increase in the memory score in a group of patients who were calorie restricted. So this is not just a conceptual idea. The calorie restriction actually helps to improve mitochondrial functioning. It decreases the amount of reactive oxygen species that are present there, and it also decreases the inflammatory factors that are going on. So normally we see that glycogen is broken down in the liver, and the glycogen makes glucose. And so when we fast overnight, we see that the glucose is produced. But now what we see in a starvation state is that there's actually an increase where we break down the fats. This is the beta oxidation that's occurring. So we break down fats. The amount of glucose that's present in the body is stabilized after we're fasting for 2, 10, 20 days. Fasting meaning calorie restriction, a 25 to 30% calorie restriction. Now we start to get more energy from the fats, from beta oxidation. Now this is also what happens when we use a ketogenic diet. For those of you who are following, the next 4 slides were from an earlier part of the talk. I moved them here because I want to relate calorie restriction to the ketogenic diet. Ketogenic diets have been used of high-fat, low-carb diets to be able to help patients with epilepsy. But we also see that the ketogenic diets, because they actually help the mitochondria to be more efficient, we find that the efficiency of the ketogenic diet allows the production of this NRF2 and a decrease in the reactive oxygen species. Now, at this point in time, if I'm you and I'm sitting in the audience, I'm thinking, this is a lot of information about biochemistry, and how do I really put it back into context? Well, what I'm sharing with you is that calorie restriction or a diet that is a high-fat, low-carb diet can have the following kinds of effects. It can have the effect, can you move that light over this way a little bit? Okay. It can have the effect where it increases ATP. It increases energy production and decreases reactive oxygen species. It makes the mitochondria more efficient. And what things will help us to increase or make a diet more ketogenic? Restricting calories, the use of something like coconut oil or medium-chain triglycerides. I have to say that for me, the awareness that calorie restriction had this kind of impact was pretty impressive to me in looking at the overall impact. But what it also showed me was that a ketogenic diet, which is going to tend to be more tolerable for patients than a restriction of calories by 25 to 30%, was going to be a useful clinical tool that I could use. So I've emphasized the use of higher fats in the diet in patients who have neurologic dysfunction that are going on. So in addition to dietary factors, we can see that exercise can also make a difference. Exercise helps BDNF to increase. So here we see an example of 138 patients. Now, this is a half a year at 142 minutes per week. That's about 20 minutes a day. And we looked at their memory scores over time. And what we found was that in the intervention group, their memory scores improved. In the other group, their scores declined. Now, it's not just from aerobic exercise. Simple walking actually can help slow the progression. Where we saw in this group, adults were walking 6 miles per week. It's not a lot of walking overall. What we found was that in the group that didn't walk, their mini mental status exam score declined by 5 points, whereas the group that exercised had a 1-point improvement. No loss. Again, exercise training helps with various parts of the brain. Here we talk about the hippocampus, the part that's involved in memory formation. And we find that exercise is a great tool to be able to use. So calorie restriction and physical exercise. And we can also see DHA, right? This is the omega-3 fat. We often talk about EPA and DHA. DHA is particularly important for the brain itself. And so here, looking at DHA, it helped to return these neurogenesis factors, BDNF levels, to normal levels after traumatic brain injury. Here we look at people with Alzheimer's disease and see that when we look at the relative risk of Alzheimer's, of the amount of DHA that you took in, the people who are in the top 40% of DHA intake have 30% of the risk of developing Alzheimer's as people who are down in the lowest 40%. So we find that DHA intake correlates with the risk of developing Alzheimer's disease. Here again we see another study. So that's just a correlation study, but here we see another one with 900 men and women. Looking at them without dementia and seeing that if you were in the top quarter of DHA, your risk of developing dementia was decreased by half. So I would ask you, wouldn't it make sense if you had patients who began to have any kind of cognitive decline going on to begin to use DHA? The studies from the Framingham Heart Study are impeccable, demonstrating that DHA, which comes both from phytoplankton and also from fish, is very, very useful to do. So I've highlighted exercise, calorie restriction, ketogenic diets, and DHA to help be able to support overall neurologic functioning. I want to finish with what are those things that are going to help overall with mitochondrial function, coming back to energy production in the mitochondria. And some of them are the same. Exercise makes a difference to be able to make the mitochondria more efficient. Antioxidants are going to help to quench the free radicals that are formed. CoQ10, using doses that range, generally I'm looking at between 100 and 600 milligrams per day in adults of CoQ10, because CoQ10 is necessary in that electron transport chain to help with energy production. Riboflavin. Riboflavin is B2. Riboflavin is involved in the molecule FADH that's necessary. It's part of the building block for the electron transport chain. It's necessary for the steps in the Krebs cycle that go on. So we want adequate amounts. When I'm looking at someone who's got mitochondrial dysfunction, their energy production is low, I'm using therapeutic doses of riboflavin that range from 50 to 400 milligrams per day. L-creatine can be used to be able to help with the formation of muscle, and it can be used to be able to help the production of ATP. So L-creatine can be used, but more importantly, L-carnitine. I mentioned that L-carnitine helps to shuttle fats in the mitochondria. And so dosing that ranges, usually it comes in a 330 milligram size dosing. And so I'm using doses that are between a half a gram and a gram twice a day for individuals. So if I see people with mitochondrial problems or energy production problems, I'm using these tools. I'm using CoQ10, riboflavin, and carnitine. And I'm looking at medications that will get in the way of energy production. So I want to make sure that their nutrition is good, that they've got a full color of palate that's going on. I want to make sure that there's not inflammation and infection. I want to use these tools of CoQ10 in doses from 200 to 600 milligrams and omega-3 fats, particularly DHA. If I'm going to give an omega-3 fat fish oil combination of EPA and DHA, I want to get one that's got equal amounts of EPA and DHA, and I'm giving doses of DHA that run between 500 milligrams and 1,000 milligrams per day. And I want to have exercise that's going to help the mitochondria to be more efficient. So what I've done is gone through the production of energy within the body and talked about its relationship, particularly as it relates to neurologic disease. But when we have patients who are depleted in energy because of oxidative stress, we have a number of different strategies that we can use. We've had a little bit more of an expansion of moving beyond the elimination diet and the anti-inflammatory fats, but we found that the inflammatory component, the driver, is still very important, but it's a downstream consequence of oxidative stress. We have tools to help us measure when there's imbalance, before there's disease, and we have tools to be able to help us to understand when we're treating disease, are we moving in the right direction? So it's my hope that this understanding about energy production and its role in the disease process, where I've focused on neurologic issues, but this also plays out with issues of fatigue and fibromyalgia and symptoms of energy depletion, that the approaches that we take here will be helpful to you in practice. Thank you very much.